Um, Fab, we'll get started as people are joining. Welcome everyone to the first webinar of the Community of Practice for Hepatitis C Care in regional and remote Australia. My name's Nikita Habraken. I'm the Director of Programs here at INSU. Before we begin, I'd like to acknowledge the traditional custodians of the land that I'm joining from today, the Darwin people, and pay my respects to elders past and present. I also acknowledge the traditional custodians of the many lands that we're all joining from today, and I would invite you to let us know where you're joining from in the chat. At INSU, we do really recognise the strength and resilience and leadership of Aboriginal and Torres Strait Islander people, and pay our respects to any Aboriginal and Torres Strait Islander people joining us today. Before we start, I'd also like to acknowledge the many people who have helped to conceptualise and shape the community of practice. So we're working with the ECA2 team at the Burnet Institute to deliver this community of practice after it was identified as a priority by the ECA2 People Who Inject Drugs Working Group. It's been further shaped by an expert steering committee and the experiences of people who are delivering and receiving hepatitis C care in regional and remote Australia, including peer workers, nurses, other clinicians, people with lived and living experience of drug use, policymakers, researchers, and program staff. I'd also like to really thank our webinar hosts, who you'll meet shortly, and all of the speakers and everyone else who's contributed so far. I'd again like to give a special thanks to the steering committee. So you can see their names up here on the screen. And now, without further ado, I am so pleased to introduce you to your hosts for the webinar series, Peter Garver from WA and Alex Wade from New South Wales. Peter is an overdose prevention and peer naloxone project officer, as well as the communication and reporting officer at Peer-Based Harm Reduction WA. And Alex is a team leader and a clinical nurse consultant in hepatology at the Mid-North Coast Liver Clinic and Drug and Alcohol Services. So it's my great pleasure now to hand you over to your webinar hosts, Peter and Alex.
Morning, everyone. Thanks for joining us today. Today, we recognise and honour the voices and the power of people with lived and living experience whose expertise fuels our shared purpose to build systems rooted in dignity, equity, and justice. We recognise the courage it takes to share these experiences and the vulnerability that can come with stepping into lived and living experience roles. We commit to supporting the growth, well-being, and leadership of our lived and living experience workforce. With love and respect, we remember those we have lost. We pay tribute to all who have paved the way, those who are with us now, and those yet to come.
Awesome. Thank you, Peter. And welcome, everybody. I'm so excited about this workshop, and I get to give you a little bit of a rundown on our housekeeping and participation. Just the general Zoom etiquette. We're well past the COVID days where we get people running in naked into the screen, but we still have some etiquette around just kind of keeping your microphone on mute if you're not speaking. It's really nice to be able to see people, so especially for the speakers. So if you have a camera, please turn it on so that if you've got enough internet for that, so that there can be a little bit of feedback, visual feedback for the speakers and for the rest of the team, smiling, nodding, whatever. If you have any technical issues, please feel free to put a chat message in, and Nikita and the admin wonderful INSU team hopefully will be able to help. Using the question and answer function, which is down the bottom in More, for your questions. We'll keep an eye on that throughout the webinars, just to try and monitor and make sure that everyone gets a chance. If you don't feel comfortable speaking up, we can look at the questions in the chat. And also this, as the recognition of lived and living experience statement kind of says, it's a really safe space. And so we try to respect the diverse experiences and perspectives in the room. So what are we here for? What to expect? It really is like the t-shirt says, it's a conversation starter. It's about getting everybody in the room and having conversations as a community of practice in regional areas and remote areas, because sometimes we have to do things a bit differently. So we're going to have 6 webinars across the year, each with a different, exciting, interesting topic. There'll be an email series in between each webinar profiling the different innovative models, as you can see there, of care for hepatitis C in regional and remote Australia. And while each webinar has a topic or theme, we also really want to open that up to just be, like I said before, a welcoming space where members can connect, chat, and share their experience with one another. We really had no idea how many people we would have, so I can see 38 participants there now, so that's fantastic. Welcome, welcome, welcome. We've got the email address there if you'd like to add anything to it. So here's what we'll be looking at over the 6 webinar series, starting with today with the peer and nurse-led models of care, going through incentives for improving HCV testing and treatment in regional and remote Australia. Webinar 3, integrated care for hepatitis C, embedding HCV care in existing services. And then moving into webinar 4 in September, engaging and training peer navigators for hepatitis C, supporting your clients every step of the way. It's like building on today's conversation and building on looking at different kind of models. Webinar 5 is around Aboriginal and Torres Strait Islander-led models of care for Hep C. And then our final webinar in December, which feels like a long way off, but it's March already, so it's pelting along. The remote prescribing and virtual clinical support, making Hep C treatment easy and accessible. So there's a real cross-section and a range of things that we'll be looking at over the next 8 to 9 months. All right, so join, please, the international webinar on peer nurse partnerships. So 21st of April 2026, this is a plug for another community of practice. To hear from your colleagues about peer nurse-led models of care for hepatitis C from around the world. Whether or not you're already part of an established model, just starting out or wanting to get some framework for what a peer nurse approach could look like in your service, please come along to this webinar. I think it's going to be a really interesting conversation again. Any level of experience is welcome. Participation can be as active or low key as you're comfortable with. As I said, if you've got the chat, you can put things in there or put your hand up. Please, it's really the beginning of a conversation, and there'll be a link in the chat to register for that webinar.
Okay, so we have an agenda for today's meeting. However, this agenda is not set in stone. It's a guide. The real purpose of us all being here today is just to bring people together to connect. So we'll start out hearing from Sal and Angie about their peer and nurse-led model of care, which is operating in the Northern Territory. And then we'll move over to speak to Julie and Maxine from Western Australia. After that, we've got some time for questions, and we've got 20 minutes set aside for a group discussion. Today, this is going to be an open discussion. However, that could change in future webinars. We're happy to be led by the group. It may include breakout groups, but we'll see how those future webinars go. And then after that, we'll come back together and wrap up and close the webinar for today. So to introduce our speakers, joining us today from the Northern Territory, we have Sal Enderman, who is a peer worker and HepLink support officer at NTARC in Darwin, and also Angie Everett, who is a Darwin Hepatitis Clinic nurse, also from NTARC in Darwin. And then our second group of speakers, we have Julie Bernking, who is a Southwest nurse, also working across the Perth Metro team. She's currently a nurse practitioner candidate from Peer-Based Harm Reduction WA, and she'll be joined by Maxine Kent, who is a Hep C case management worker, also working at Peer-Based Harm Reduction WA. And now we're going to have a quick poll for a little bit of fun. Here it is. Okay, so question 1. Where do you mostly work? Let us know what state you're joining us from. Here we go. We've got a lot of Queenslanders in the room. Awesome. Great. Thanks, everyone. Okay. Next question. Where is the next question?
Coming, sorry.
It's great to see so many people joining us from all around the states and territories in WA. Question 2, what is your primary role? Pick one of the options on the screen. Let's see. Oh, we have so many nurses in the room. We've got peer workers, we've got project staff, researchers, community workers, lived and living experience representatives. Someone's ticked other, so I'm curious about that as well. Nurses are certainly leading the way. Oh, doctor, there we go. Thanks, Amanda, welcome. Awesome. Nurses have won the day. Okay, question 3. Are you a part of any other communities of practice? And maybe you might like to type into the chat if the answer is yes, what communities of practice you are a part of. Let's see. Okay, someone's not sure. Welcome to the club on that one. So type into the chat which communities of practice that you are a part of. And people might be interested to check those out. Awesome. Question 4, for a little bit of fun. What is one item you couldn't do without in your work? Can't wait to see. We've got one answer so far. Comes some more. Hey, Alex, what's one thing you couldn't do without in your work?
So it's funny you ask, because my first thought was tourniquet, and then I thought, actually, I've used gloves and we do point of care testing, so we often don't need it. So even though that was the first thought, it's like, oh, I can actually do without it. So it's, I guess, a flexible attitude might be it.
Yeah, right. Well, mine would have to be my demo kit. Provide a lot of workforce development and training. And a part of that is talking to people about things like safer injecting. And so I'd be pretty lost without my demo kit full of equipment. People have put in the chat, coffee. Yes, coffee is great. Thanks, everyone. Great. Okay. And so now let's hand over to Sal and Angie from the Northern Territory to talk to us about their nurse and peer-led model of care.
Please get rid of our notes. Thank you. Sorry. Hi, good morning, everyone. I guess before we start, we'll just like to acknowledge that we're presenting today from the lands of the Larrakia people up in the Northern Territory in Darwin. So thanks for joining, everyone. And I guess, yeah, a silly first front page. We had a bit of an AI blitz the other day. Everyone was using apps, and this was great. Just put in some pics of us and what we do and where we are from, and we got a nice mango backgrounded Northern Territory. But yeah, that's the very polished version of us. If we can just move to the next slide, and that's what we really look like. So I guess we'll just wanted to quickly run through how our model of care works and how we work together, and I guess what we each bring. So I guess that for me, what I bring, I guess, is the clinical components to the occasion of our the equation to our partnership. You know, I'm the one that takes the bloods and does, you know, follows up the results. And having finished my nurse practitioner stuff 12 months ago or so, that was great because now I can also just follow through and do the treatments as well. So, and I guess I found another big thing is just helping people navigate the healthcare system and trying to get people linked in with other services and things that might be happening in their life. And then the wonderful Sal.
I think you just skipped off.
Oh, I've just completely skipped screens. Sal can tell you the wonderfulness that she brings. There we go.
Thank you. Hey, I'm Sal. I come from a space of lived experience. I'm lucky enough to work in a rehab as well, and that keeps me up to date with current local user trends. Over the years now, I've become a trusted face within the community. I managed to get people in the door, keep them engaged. I back up Angie and assure clients safety and respect. But it's more, it's really about being that effective conduit between a highly stigmatized population and a medical experience.
Absolutely. And she does that very well. And I think just as a team, like we just collaborate on everything. I think we are quite reflective in our practice and not much really. Yeah, we're just always constantly checking in what the other one is doing and making plans together, I think. And we just kind of laugh that our personalities, I think, are quite similar in many ways, which helps, but we'll bang on about that a bit later. Sorry, these slides are a little bit dull actually, but it kind of gives you a bit of a picture of how the Nurse Peer Partnership works and how it came about for us. It started off back in 2020 actually. It was funded by EC Australia as part of the work they were doing, but we had a little hiccup with COVID, as we all know, and then Sal and I started working together in 2021. Yeah. But prior to that, there was a lovely nurse, Jacqueline, up in Darwin, who was doing monthly clinics down at the NSP, and you know, she did get a good attendance, but there was just so many things raised about, you know, once a month it wasn't enough. You know, people forgot what day of the month she was coming. You know, people wouldn't turn up. There was a few, like, people wanted the service, the community wanted the service, NTARC wanted the service, but it was just, we just needed to bulk it up a bit. So when we got the EC funding, it was like, how can we make this work? And peer work was obviously a huge part of that. And so we kicked off what we've been doing now for the last 5 years, essentially. Let me just see if I've missed anything else. But yeah, so now we do a weekly clinic where, yep, it's just a walk-in service. We still do outreach. We still get in the car and go and see people, and whatever else we can do to help people get through or get tested and get treated. And then we've also got a really good relationship with the local health service as well. So I'm kind of in a position where I sit between, I work as an NP with the Royal Hep Service and I work as an NP with NTARC, obviously. So a lot of the triages that might come through to the hospital for Hep C clients, they can often just flip to me and I can make contact and offer them this pathway or that pathway. And we've been getting good uptake there. So that's been really nice. And maybe we can just move on to the next screen. All right. So yeah, I guess this is again another these have been made for a paper that I was trying to write. So yeah, this is kind of, I guess, overall what it looks like. You know, we've got the community that we're involved with. We're based at NTARC, our NSP. We've got NSPs. We've got a satellite NSP in another part of Darwin as well. We work with primary healthcare and the Viral Hep Service, as I mentioned. We've got really close ties with them. So we get people in, and then Sal and I do our bits, work our magic, where we can obviously do the testing, we can do the treatment. I've got access to a FibroScan, which I can bring in each week. We've got those fast track referrals. And then it's been really good. I've noticed in the last couple of years that, you know, being able to then have that continuous care for people post-cure and then ongoing HCC surveillance. So that's been really important, I think, in being able to bring something else to the service. And yeah, what have we got there? Our outcomes. we want to achieve SVR. I think we've had really good rates of that.
Yep.
Being able to keep people engaged for that time and bring them back in for SVR, and then again, continuing to remain engaged and then coming back for retesting and things like that. We've been able to provide incentives on and off throughout the time we've been doing the kind of work that we're doing. But yeah, I think we haven't practiced this, so I'm a little bit lost, so bear with me. What else? And I guess, yeah, we've had situations like the tertiary services. I guess it is that ongoing. It's not just this in this moment of dealing with the hepatitis C. We're helping people get in with the rehabs if that's something that they want to do, organising all their other chronic diseases. I think we've had luck with that, just getting people into that, back into, going and getting their mammograms and their CSTs. And if they haven't seen, the GP for a while and there's other things ongoing, we've kind of been having good luck with that as well.
It might be someone's first positive experience in a medical environment for a very long time, and they seem to get some encouragement and step up to take care of other aspects of their general health, and we're referring on for mammograms and
it's been really
like all sorts of stuff, all manner of things. It gives them confidence to re-engage, which has been really positive.
And I think that just having that support in navigating the system as well is a really big thing. And I think I just noticed there we've got oncology down there, so I think that's also been a big thing, particularly through the nurse peer model. We've had 4 HCC, 5 now, I think, diagnosis through this model that we've picked up through NTARC and supported people throughout. And we've had some really good outcomes actually, but that's a whole nother topic. But yeah, so just involved in that whole oncology space as well with people. Next. Oh, ignore that. I think we were meant to give a bit of an example, I guess, of a patient journey and how this works, and and why it works. So I don't know whether you want to give a bit of a rundown of.
Well, a standout one for us was a referral we got from the local ARCHO for someone who was spending a lot of time in a mental health ward and was highly resistant to any form of treatment.
I think they'd previously started treatment, but just with what was going on, adherence was not great, and there was a treatment fail. So it took the GPs a while to convince her to
even
talk about it again.
Yeah. So we went around there and attended an appointment where we met this young woman, and she had incomplete treatment, and her mental health and her drug using choices were interfering with her housing issues and child services being involved, and she was really reluctant and quite a hard ass for us to try and engage with. But the minute that I started disclosing my lived experience and, that my family and other people in my life that I love dearly and care about were current drug users, she really softened hugely, and quite an effective bond was formed and a great rapport straight away. We saw her through her entire treatment process and stayed engaged with her for quite some time in social supports, and just encouraged a lot more positive engagement with other services and health issues, didn't it?
It was really good. She ended up bringing some of her peers in to be tested, and there was some positive cases in there as well that we treated. We had a lot to do with her. I think we became her safe place. Sal was very good and supported her with a lot of her mental health appointments and things like that for a while. But it was really good, and I think that I would have had no hope, I don't think, of cracking her that day. She was pretty unimpressed with us in the GP clinic and giving us lots of stink eye, and I'm not going to be doing this, and I'm going to still keep using, so I don't know how I'm going to do the treatment. And
it was so great to be able to tell her that her choice to use wasn't going to be interrupted by the treatment. And I think that really empowered this woman at the time.
I think you did have your get clear on the gear shirt, so it was like it was all just ended up quite lovely in the end. But yeah, it just goes to show, I think, the importance of that, the peer with the lived experience in that space.
With that for that one.
All right, what have we made notes here? So we're just going, we were given a bit of a template by these guys to kind of topics to talk about. So the things that are working well. So I guess you want to talk about
Incentive when available. It's certainly helps hugely in facilitating engagement. The choice of testing is another positive with the venipuncture or point of care. Going to meet people where they're at is huge, and being flexible, person-centered care plans for transport, food, check-ins, medication drop-offs, collecting prescriptions for people and dropping them to their homes, home visits for bloods even, and care continuity beyond cure, including HCC surveillance in community. Support to navigate the system with appointments, transports, and emotional support, and operating out of a DUA, operating out of NTARC.
I think so. From what's been working well for the service itself and how it runs, and I've talked about this over the years that when I've presented stuff, we're really lucky. I think that we started off as a partnership with the local health service, and it's kind of we've continued that MOU. So we have the shared electronic record. So I'm able to sit in the clinic and look up a person's health record and look up their past, serology, look up any treatments, get a really clear picture of what's been happening. And not everyone has that, but it's really helpful just to speed things up when you can see what's happened in the past. I can look at their past imaging. I can look at it's wonderful. And then that again makes it really easy for me to refer quickly and know what things we need to do. And I think again, just have now the whole nurse practitioner gig. It's been great being able to close the gap by actually being able to prescribe the medication as well and just get on with it. So, and what's been working for the team?
The nurse peer team has trust. It's strong. It's respectful working relationship. We have really open communication and problem solving. I'm really matched so luckily with Angie that I feel like an equal in the space with a clinician. And that's what's really helped the whole way along. I bring something to the table that Angie doesn't have and vice versa. And to come from the lived experience space, that's been really empowering for me. And knowing that my peer role and seeing that my peer role is genuinely valued by the service and by the community as well. Yeah, and it has led to ongoing employment and sustainability for us both.
Yeah.
We're valued here at NTARC, leading to sustainability of the model and ongoing employment opportunities.
Yeah, we're getting there in the end. It has been 5 years of research funding and this and that, and how we're going to make this permanent. It's been tricky, but Sal, I think we've got some guaranteed years in us now through different funding, so that's been really exciting. To we can start planning more. Next. Oh, these are just some of our old things. Can't even remember what was the topic about? Challenges and learnings.
The number one thing I brought up was that the learning never stops.
Yeah, absolutely. I guess over time, as we're saying, we're talking about the funding, it's like it was quite constrained by the limitations of our funding on and off over the years, relying on research funding. So we kind of didn't have that sustained commitment from the local health service. What else? Funding limitations. Yeah, so I'm just here reading my notes. And I guess, and that's been the other thing as well, I think, just with the funding, trying to involve more peers, but then not having that, we don't know how long it's going to last, casual employment. But, we're very, very lucky that we've got Sal as our constant guru. And when we're able to bring extra people in, it's been really good. What would we do differently? We've always been quite cocky in that respect. I think we'd say we wouldn't do anything different. Like, I think I don't know that we would change anything, because we didn't know what the hell we were doing when we started, and we bumbled our way through it.
We built it from the ground up kind of thing. Yeah.
We tried things that didn't work. We'll try something else. And we were really lucky to be in quite a flexible space that we could try different things. And I think I've just made a note here for myself in regards to research as it started. I think if I could go back now, if it's anything to do with that whole research in this space, I would come up with a better way to record those observations and those conversations that you have with clients, the things that they tell you, the statements that they make. I just think it's so important. Like, you remember them, but then when you want to share them, you need to have some evidence. So field notes, people, if someone says something, you're like, that's gold. Like, I think try and document it so you can pull it out for these kind of events. In summary, I've written here, I think, we've successfully delivered a holistic person-centered care. We've addressed some structural and individual barriers that we've identified. The value of combining that clinical experience with lived experience to improve outcomes is it's undeniable. And the insights from this model, I think, just go to show that, there's lots of other things happening in this space, and there's already people doing it, and we should be doing it a lot more. Key takeaways. I think that's a great thing. The peers, not the support. They're the access to the pathway into this into Hep C care. Working together, system integration. I think I'm very spoiled that we have that access to the health systems records and stuff. It's really medications. Yes, they're brilliant. I'm very spoiled. I wasn't around for the interferon times, only these fabulous drugs. So all that's really easy, but it's really about the relationships that we build with people. And for people, I think looking at going into something like this, I don't know. I always say Sal and I are just blessed that we've hit it off from day dot. Like, I think it is really important, the people that you bring together. I don't know, it wouldn't work for everyone. I think we hit the jackpot. Yeah. So I think you need to find your compatible people who work well together and just have that respect and a passion for it. I think we're complete suckers. We'll do anything for anyone to get them over the line.
To get them across that line, yeah.
Yeah.
And that's us, really, isn't it?
I think that's about it. But it's completely, it can be replicated all over. I think it's just got to get the right people in that space. And sorry, it was a bit disorganized, guys. We did not. Oh, I just said it all. So sorry.
Thank you.
We'll let the next professional show you how it's done.
Thanks so much, Angie and Sal. That was awesome. We have had a couple of questions typed into the chat. We'll hold those until after we hear from our next speakers. But just so that you are aware, there is a question and answer box, and you're able to put questions in there as well if you wish. And so now, moving right along, let's hear from Julie and Maxine from WA.
Okay, well, hey everybody. I, after watching that, feel even more disorganized. We haven't practiced this either, and we're in different locations at the moment because I travel all over the place. So let me just make sure that I've got this again. Is that right? Does that come up? No? Does my screen sharing come up?
Yes.
Woo.
Thanks, Julie.
Yes.
Okay. All right, so I guess we're with Peer-Based Harm Reduction WA. I'm Julie, and Max is currently in our other office. Peer-Based Harm Reduction WA is obviously peer-based, and we have fixed site clinics located within the NSCPs in Perth and Bunbury, and then we do outreach throughout Perth and through the southwest of WA. Let me try to figure out how to skip my screens. Nope, that's not working. Hang on, sorry. We work across different lands. So Bunbury Clinic is located on the lands of the Wurundjeri people. And at the moment I'm up in Perth, which is Boorloo, Whadjuk, Noongar land. And then we also actually extend out through about 280 kilometres from Perth is roughly where we reach out to in the southwest, although occasionally we do outreach down into the Great Southern, like Kinjalling, and that's about 400 k's from Perth. So it depends. Please feel free to jump in at any time, Maxine.
Yeah, I mean, we love to drive.
Yes, we do.
But that is part of what we do. We have to stretch out in regional areas and be seen.
Yeah.
For sure.
For people that aren't in WA as well, we aren't quite the same as the East Coast. There isn't a lot of large cities in between each space. Bunbury's like the next biggest one from Perth, and that's a couple of hours away. And then the smaller
the next
towns.
biggest is like Albany.
Yeah, and that's only
Yeah.
like 20,000, 25,000.
Yeah.
Our slides aren't as great. I haven't had as much time to shove in some really great photos, so we're lots of words, sorry everyone. But our model exists because the team actually went in and had a consultation with consumers. They had a audit, contacted everyone who'd previously been tested, dropped away, focus groups, just to see what would work best for the people actually accessing our service. And then it was built around that. As I said before, we're actually based in an NSEP, so it's a slightly different way. We're not bringing peers into a traditional setting. It's actually, well, the clinician going into the peer setting. So it changes up the hierarchy completely, which is kind of cool. That consultation process informed our model of engagement, treatment, and ongoing care. Previously, there was like the same as I think a lot of other people see, lack of trust in traditional care systems. There was still a bit of a hangover of misunderstanding of the types of treatment available that was being repeated, I guess, to others. So getting that message out there that's how long this model's been around, basically, because it's from when the DAA started. Accessibility issues, competing priorities is such a big issue. Why it works for us is that it's a better experience for our consumers, increased continuity of care. Our caseworkers can check in regularly, as well as escalating clinical concerns. What else? Max?
Well, I probably should introduce myself properly.
Oh, crap. Sorry.
No, that's okay. I just feel like I should do it. That
Please do.
Julie, and obviously we work together, and I work also with Jody, the team leader here, closely as well, and I support Julie on the road in a similar role. You know, we've got strengths and weaknesses, yeah, but we're there for each other, yeah, for sure.
She's underselling her role completely, by the way. Like, I actually can't function very well.
I give out lollipops and stuff like that. But yeah, it's a varied role, and yeah, really enjoy it, and you know, glad for the people that I work with, for sure. Right, there you go.
We have, oh, it's not coming up. Yeah. Nope. Oh, there we go. Oh, apparently I have to click on it. Sorry. Yep. So it's an open door policy. There's no appointments. So for our fixed site, people can just come in and see whoever's available. So it doesn't have to be the nurse, because our caseworkers are trained in phlebotomy and fibroscanning and a lot of the testing pathway and pre and post counselling. So it's not, tasks aren't relegated to clinicians only, or clinicians, because it's teamwork. So we just try to get the whole process done together.
We show that we work together. We're not separate from each other, really.
Yeah, like decisions are made together as well. Some of the, like the outreach, where we go to do outreach as well is a combined discussion about where we're going to go, where we think is going to be suitable. It's not just come along with wherever we say. So that's kind of cool.
We have to figure it out in advance wherever we go, because we can't just go there and expect it to work.
Yeah, that is, I think that might come up in challenges and learning as well, because we're quite we have some very I don't know if you can hear me. It's WA gets very conservative the more regional you go with it. And there's drilling going on here, so that's great. The clinic model expanded through outreach into the to the home sort of part of it from 2018. So it's been going on for quite a while. And the ability to meet people out in their space is something that has been addressed before as well. But we can also arrange for our caseworkers to stop by in a way that's suitable for the consumers as well. Like it can be daily, weekly, whatever works for them. So there's a lot of negotiation there.
We go on what the consumer wants, what's best for them, what they're comfortable with. It's not about what's best for us.
Did that skip ahead? I don't know. Somewhere in here we had, like they suggested a real world example. This was one of our clients who, did you want to start this, Maxine? Because it's really your story that you brought me into.
Yeah, it's a client that I had done outreach to, and he disengaged from the service on that level. And then so I just started going there regularly, and I would drop water off to him and juice and stuff like that. He didn't necessarily know it was actually me, and then he kind of figured that out, and then through that we slowly got him, his trust. And I was able to bring the nurse in the van one day, and he was happy to see her, and it went from there. And then Julie built a relationship with him as well, so he trusted us, in that space. And it worked out pretty good, but it did take time. It wasn't a really quick process. It was quite a long process, and I find that in this regional area that is often the case. It's a long process, and you've just got to stick with it and hang in there.
It was great because he did get to the point of being retested for Hep C as well by us, and had re-engaged pretty well. Plus his wounds healed up really good, which I was pretty happy with. Yes. And I think the relationship building, particularly in regional areas, is something that, even because I work in the city as well, that people don't quite see that level of engagement that we have to put in the regional areas. Say we go out to an outreach space in Perth, we might see 20 people and we can't handle any more people, whereas in regional areas we might not see more than one person the first time we go out, and then it's a slow, hi, these are who we are, we're coming back again, you can trust us, and slowly builds. Really,
it's a real process, and it's like Australia, it can take a long time to get across it.
Yep. Okay, what's going well for us? So being located with the NSEP, there's a clinician on site, not only for Hep C presentations, but also for people coming in for wound care or other concerns and health concerns. Also, we have, still NP so it's an NP-led service, and our NP writes scripts for Hep C for us and for other things that come up, because we do STI testing as well. Our peer worker can engage and keep people hanging around our van whilst other people are seeing other patients, or vice versa. Peer workers seeing the patients can see patients. Sorry, I'm just having a look. Being visual and present at events. I think this was to do with being regional as well. Turning
Yeah.
up regularly and engaging and repeating that message. A lot of times in these sorts of spaces, you know, there's vans out there that are very brightly coloured and play music and stuff to bring people in. Can't really do that in regional WA, but we still show up at a lot of places. The way our van is set up is that we have like the NSEP at the front and then a clinic at the back, and it can be separated off, but we usually actually leave it open even if we're not seeing anyone who might be engaged in the NSEP, because it
Yeah.
gives us a talking point and it normalizes it, and repeating that message instead of it being hidden and driven away, which
Yeah.
seems
So we keep the doors open, but we don't make that the focus, the exchange in the front. Yeah. So if people ask about it, obviously we'll talk about it, but we don't make it a priority in, the regional areas. We more focus that it's a health clinic, but obviously we don't hide it either, what we do. Yeah, but it's for people, and we have, had contact from people that way as well, where they've been a bit shy about it, stood back, and then they'll come up later and ask about the actual NSEP part of it. Yeah,
yeah,
it's been really valuable.
and
Yeah,
it's really little steps that we need to take
yeah,
in those regional spaces, because we have had I suppose I guess up to challenges, but we'll get to that. Also incentivization, cash.
absolutely.
That
Cash is
definitely
king.
helps us. So yeah, we pay people for testing and then for treatment as well. Challenges. That is definitely something for us. We've got really small staff, so we have in our Bunbury office, we have a couple of people who are based inside the NSEP, but then as far as outreach goes, it is mostly myself and Max, or Jody, our team leader as well, who's on the call somewhere else. And everyone's part-time, it's extended distances. So burnout's a bit of an issue that we need to look at as well, because trying to do a lot with just that number of staff is difficult. It's also negotiating then if people are sick or away or
those are the challenges of being in a smaller area, in a smaller location. Yeah.
Yep. We can't leave the NSEP with one person there. We've got to have somebody else there, and which is more important, our outreach, or it's negotiating those is actually very time consuming. And I guess as we started to say, is that regional areas, small town syndrome. So, people know each other. If you've seen coming up to a van, that they know what it's for, which is why we are very careful about sort of branding a health clinic outreach when we go out, because it lets people walk up to us a little bit more freely without people going, oh, you're going to the needle van. And
they could just be getting coffee.
Yes, they could. And
coffee.
Like I started to say, is that some of the regional areas that we've gone to have been challenging. We had one place that we stopped at where the woman was concerned that we were letting people inject inside the van, and basically we got driven away from there and haven't been able to go back to that space.
And we did, we were working on the health clinic as it being a health clinic at that time, but because it's a small area in a place that's risk adverse, she was really shut us down really quickly and wasn't interested in really knowing that. And that happens because you can see by people's reaction. Yeah, that's why. Yeah, it can be really tricky in the smaller places that we go to.
Yeah.
Yeah.
Yeah. And, the pressing priorities, the competing issues for people. If it's asymptomatic, they don't really want to attend to it right now, which is where similar to what Darwin was saying, or Northern Territory was saying, it's what we can do to assist along the way. Having caseworkers who can go drop off water, juice, or just check in is nice for keeping that engagement. And we kind of look at it as, well, I do, as like a plate. You know, people have got so much on their plate. If we can take one thing off, then maybe they will be keen to do the treatment as well. And then it's taking another thing off. And whatever we can do. We've had like small grants along the way where we can do things like make dignity packs and hand those out to people, because we're seeing a greater increase of homelessness everywhere we're going as well. And just being able to give people some toiletries and things like that makes it feel like we're doing something.
Yeah. And we're constantly learning, well, I am, about people and the areas that we go to. So one area that we've visited regularly, we now have a thing where we are recognised in a really positive way, but that has taken quite a long time to get there. Yeah.
Definitely.
But it's the learning about people and being open to them, is it always learning that.
That's what I think too. Going back a little bit as well for being regional, when I first started in this space, I was working in emergency, and it actually took quite a while for people in the regional area to trust me, even though like we get the trust from being in a peer-based service, because there's only one hospital. If you turn up in the emergency department, the chances of seeing somebody there is quite high. So I had to prove that I wasn't going to go, hey, I've seen you somewhere else. And that took a long time as well. And so building that on top of where we're actually working was, everything's relationship building.
And in smaller areas, the same thing, because I have a second job and it crosses over. So I have a similar experience with people where they know that they've seen me somewhere, but they're not quite sure. So, but it's always creating that positive connection.
Yes. Somebody's drawing on our thing.
Yeah.
Okay, cool. So our key takeaways were just like, it needs to be a team, and which it's peers aren't just like a tacked on person to drag along with you and pull out when you need to. It has to be true shared care to make people feel involved. And I mean, it's different for us anyway, because it's the roles are flipped. It's nurses going into peers spaces instead of the other way around. Checking the ego at the door, I think, is a huge thing, because as a nurse, I'm being allowed into spaces that I wouldn't normally get access to. And you've got to recognize that there's no authority that should be higher. And I think that's about it for me. And because we did this from different spaces, and at the last minute, I didn't get hold of Max, and I asked one of our Perth caseworkers their perspective as well. And
would you like me to read it out?
Oh, yep.
Yeah.
Sure.
No, and I can mention name. This is from Shay, and it's, in her words, first job she's had in a long time, and she feels like she's doing something worthwhile, as well as being in a space where she doesn't have to hide who she is, which I think is perfect. Yeah. And for me, it's being able to connect with people, because that's really a huge part of it, and working together.
Yeah, I think that's it for us. Should we address the questions? Because I can see something, or should we just move on?
I don't know. I can see you now.
Thanks so much, Julie and Max. That was great. And we have had a few questions. We are running out of time. And actually, a lot of the questions have already been answered in the chat, which is fantastic. A couple of them haven't, though. Maybe we've just got time for a quick one or two before we wind up today's webinar. Hang on. I put them all on a Word document. Here they are. And so someone had a great question for Sal and Angie. Hi, Sal and Angie. Do you have any tips for measuring health outcomes not specific to hepatitis C that you achieve? Re-engagement with primary care, first positive healthcare experience, mammograms, etc.
Sorry, that's how, what was it? How do we measure our outcomes?
Yeah, do you have any tips for measuring health outcomes, not specific to hepatitis C?
No,
No, we don't really, do we?
no. I think everyone's just so different. So it's like whatever we're able for that person, if it's like for me personally, I always feel it's really important to have that, just give them a good experience with that, with a clinician. And it's like you hear such horror stories. And it's like, as long as I walk out here and go, I felt listened to, and, I'd go back to that person or, whatever, that's really important. And all those other things are just additional. But yeah, like what a great outcome if someone goes and follows up with their GP and gets a general health check, or we can do an STI screen and, sort out all that other stuff as well, just while they're there, or I don't know, yeah.
I guess I hang on to the cultural stuff that happens. Like we've had a remote living community man, an Indigenous man present, and he noted to me when I was transporting him home how Angie respected his body, and he explained how he was listened to, and as I know, as a white woman engaging in an Indigenous cultural man in that manner and getting that sort of feedback, that was like trophy worthy to me.
It's a really good question, and I think something that has come up through both presentations is about data collection and about being able to evidence the work that's being done around just the Hep C testing. And there's been a little bit of questions around like how to get a FibroScan and things like that. And I think sometimes being able to evidence the work gives you the leverage you need to then be able to request funding and things like that. There's just that someone finally found the Q&A thing. Thank you for that. A question in there that what challenges do you see in linking people who test positive for Hep C to follow-up care in regional areas? And I think this is one of those big questions. So given that both areas are quite broad with the NT in Queensland, how have you closed those gaps between test and treat, which was also asked in the chat by someone.
I know, sorry, is this from WA one? Oh, sorry, I'm answering someone typing to someone's question. Sorry.
I guess trying to the currency and local info is what we lean into. When we lose someone off the radar for a little while, when we need follow up, we have some success in tracing back who we know or what circles they might be socialize in, and then combined with Angie's ability to find people, she'll see if online if they've engaged in any other service anywhere else. And it's a combination of those things that helps us follow up. But we do lose some. But having been in the gig for a few years now, they pop up again.
I know, that's what I think. I just say they're never off your radar. They're always floating. Like you just know who you need to catch up with, whether it's 2 years later and then you hear something, or and then we're onto it. So it's just, yeah. And I guess we're lucky in that sense that we're in a small, it's not a huge place. Our numbers aren't huge. It's like we know everyone and we're good, ears to the ground, and we'll sometimes it's been some great stories where it's taken years. And it's like, no, we got there in the end. Loops completed.
Okay, great. Well, that brings us to 10 o'clock. I want to thank everyone for joining us. We didn't actually have much time for too much of a discussion, but I think today's webinar has really covered a lot about nurse peer models of care and some of the challenges that these partnerships face, and some of the things that are really helping to welcome people back to healthcare, which is essential to the elimination of hepatitis C. And so, thanks everyone for joining us today. And we'll see you online for our next webinar. I can't remember the date. Nikki, can you help me with that?
14th, I think we have there, it's the 14th.
21st. It says the 21st of April.
Well,
in a couple of months' time.
May, 14th of May.
Okay, well, Thanks for joining us today, and we'll see you all online
Thank you
for the
all.
next webinar. Thanks, everyone.
Yes, fantastic.
Thanks to our speakers as well.
Great,
Bye.
thank you.
I'm gonna, I haven't